Morning, all. And good afternoon, I should say. Now we are 12:02, and we want to get right to the program. And so we're going to give you some basic information for about 2 minutes and then turn it over to Valerie because today is all about CDPAP. This is our law firm, and most of you know us by now if you've been brought or listening in to Medicaid Mondays. This is what we're going to cover today briefly, the new Medicaid numbers, and then going through the CDPAP, the options for completing transition, making the switch, the role of the facilitators, the active litigation that's going on. I don't know if we'll get into that, but there are 17 lawsuits being monitored around the state of New York. And then what's changing, what's not changing, and what it all means to you and to the people that you and we serve. So, Frank, if you would just give us a quick rundown on these Medicaid changes.
Sure, no problem. So this is our first Medicaid Monday since we have the new numbers finalized because the federal poverty lines guidelines were finalized. So for an individual, your income limit now goes up $68 from $1,752 last year to $1,820 for this year. If you're a couple, it goes up $82 up to $2,453 for combined between the two. The community spouse resource allowance, the $39.48, we already had that one, and the $50 for somebody in a nursing home, we also had that one. So those are your new income numbers.
And there is legislation, I understand, to raise that to $128 a month. I'm not sure where that's going, but to bring it up from 50, where it's been for over 30 years, and resources.
So again, we have some good news. It's limited, but we do have good news. So we did see an increase in these as well. So your resource allowance went up $1,221 up to $32,396 for a single person and up $1,469 for a couple. So that new number is now $43,781.
And finally,
and then we had these previous, but again, the regional rates for your penalty calculations also did go up with the new year. Most surprisingly to me is that Rochester now is the highest region, but other than that, we did have these in our past Medicaid Mondays. So if you're doing penalty calculations for a look back period, these are the new numbers you should be using. So there you go.
Resources, income, and average regional rates, all now adjusted for 2025. You plug them into all the different things that we do with them, calculating penalty periods and looking at increasing income allowances, resource allowances, and what we can protect and preserve for our clients. With that brief introduction, I'd like to introduce our primary speaker, our featured speaker for today, a very good friend of mine and colleague and someone who most of you know. That's why you're here on today's broadcast. And that is Valerie Bogart. And Valerie is with New York Legal Assistance Group. She has been part of our educational forums for many years now and part of the education of the Bar Association, both in New York and across the country. And with that, Valerie, I think we're going to give you slide control. Welcome. Thank you so much for joining us today and helping to educate our audience. You're muted, so let's get your voice on.
Okay.
There you go.
All right, that's first. Thanks so much for having me today. This is such a critical time for people who receive Medicaid long-term care in the community, as there's huge changes happening that really threaten services. So I'm really happy to be here. I'm not happy about the changes. I do work for the New York Legal Assistance Group. We're a nonprofit that does legal services in New York City, and we do statewide advocacy on long-term care. Our own program does a lot of training like this, and we represent people in New York City. I hope you look at our website, nyhealthaccess.org, and there's a link to the article about CDPAP right there on the screen, so you can find changes. So March 28th is just a little over 2 weeks, a very unrealistic but very real deadline that the state has set to make this huge change. So what we're going to start is with some level setting. We use the word CDPAP, but you're not born knowing that word. We're going to make sure everyone understands how CDPAP is different than other home care services, and how does it work now, what is changing with the move to a single fiscal intermediary, the steps that consumers and aides must take to make the transition, And then some talk about why is this happening. And the last slides are some resources. So what is CDPAP? It stands for the Consumer Directed Personal Assistance Program. It's a 45-year-old Medicaid program that was started by people with disabilities who wanted more control over their lives. They were fighting a medical model where a nurse came in and did tasks for them and told them what tasks they needed. And they said, no, we know what tasks we need. We can train our family members or buddies to do all sorts of sophisticated nursing tasks and let us do it. Let us control our care. So that's how it started, and it's expanded, of course, a lot since then. So in this program, the person with disabilities, who we call the consumer, is the employer of the aid. They're not paying them. Medicaid is paying them through a complicated scheme that we'll talk about, but they are the employer. And what's important to remember is that with CDPAP, like all home care, it's got to be approved by either an MLTC plan, or if some people are in a regular managed care plan called a mainstream plan, or some people get services from their local county or New York City HRA. Those are the entities that decide whether you're eligible for CDPAP and how many hours you get. And the fiscal intermediary is what's changing. That's the entity that has the contract with the MLTC plan or the managed care plan or HRA or the local Department of Social Services to handle payroll, timesheets, electronic visit verification, and benefits. So just to compare, about half of all consumers who get home care are in CDPAP. I think it's definitely more upstate, and it might be a little bit more altogether. It's roughly half compared to traditional personal care. So how are these different? For one thing, the names are different. The aid is called a PA, or a personal assistant, in CDPAP. Whereas in traditional personal care, it's called a personal care aide, or in New York City, we used to call it a home attendant. That's the same thing. It's the consumer who hires the aide. In traditional personal care, that employer is a licensed home care service agency called a LICSA. And sometimes we just call it a regular home care agency or traditional home care agency. But it's the consumer who recruits the aid from their church, from their neighborhood, from and from their family, though, as we'll talk about. Family members can do it. If the consumer doesn't have the cognitive capacity to do that, they have a designated representative who performs those functions of recruiting, training, scheduling, supervising. It's usually a family member, but it's not always. It could be a geriatric care manager. It could be a friend, a neighbor. But all of that in traditional personal care is done by the home care agency, the LICSA. Who pays the aid? Again, it's the fiscal intermediary, or FI. That's an acronym you're going to hear a lot, compared to the licensed agency. Now, here are some big differences that are really important to keep in mind from CDPAP compared to traditional home care. In CDPAP, the aides, the PA, is allowed to do skilled nursing tasks that normally a personal care aide is prohibited from doing. For example, let's say the consumer cannot take a pill and put it in her mouth and swallow it. Someone else has to put it on her tongue, or has to mash it in some applesauce, or someone else has to inject insulin or put in eardrops. In CDPAP, the PA, or the aide, is allowed to do all these things, even tube feeding. suctioning tracheostomies. And that comes again from the root of CDPAP being from the disability rights movement, saying, let us control our care. We can train our friends and family and neighbors to do these tasks. In traditional personal care, they're not allowed to do those things. They are allowed to administer, to help with administration of meds, but not actually put a med in the person's body directly. So as a side note of that, it's a consumer who trains the aide because they take responsibility for doing it. In traditional personal care, there's 2 weeks of training for personal care, 3 weeks for home health aide, and they have to be certified at the end of that training. Now, I want to have an asterisk here that the governor has said that CDPAP is going to start some required training. And we actually think that's not, that actually doesn't comply with a big source of funding that the state gets called CFCO, Community First Choice Option, which says the consumer can train their aides. So that's going to be a fight about whether they require training. But no aides now who join PPL are required to train yet, okay? Another big difference between CDPAP and traditional personal care is that most family members other than a spouse may be hired as the PA, as long as they are not also the designated representative. So that means if you have an elderly consumer, their child can be the PA. If you have an adult child with disabilities, their parent can be the PA. Now, the parent cannot be the PA for a minor child. That's not allowed. But for an adult child, they can be. Even a legal guardian can be the PA as long as someone else is the designated representative. And we have the sites to that on our website in the article. But a spouse can never be hired as a PA. So, but in traditional personal care, you can't hire your child to be your PA, and you can't hire your parent to be your PA. So, but you can hire a cousin or a sibling, but so that's a big difference, okay? Now, how are they the same? All right, just want to make sure we're all on the same page here. Both services have to be authorized by an MLTC plan that the person is enrolled in, or if they're enrolled in a regular mainstream Medicaid plan, that plan authorizes the services. Or if you're not in a plan and you get services from your local county, for example, people in waivers like the OPWDD waiver or the nursing home transition waiver, if they need CDPAP, they get it, they apply for it from HRA or their local Department of Social Services. So CDPAP is always authorized by those entities. And that's those entities that decide how many hours a week you get, whether the consumer is able to carry out the responsibilities of CDPAP. And it's those entities that have the contract with the fiscal intermediary or the LICSA, the home care agency, that say, we're approving this person for 8 hours a day. We're going to pay you for 8 hours a day. If I handle all the paperwork and the payroll and the benefits and the electronic visit verification. So now there are over 600 FIs in New York State, because the state, from the very beginning, basically said anyone who wants to put out their shingle can do it. And now they're upset that there are so many FIs. But it was the state's own fault that they didn't do it in a controlled way with an RFP or anything else before. But now they're shocked that so many companies have put out their shingle. So, but if you can't just go to any FI you want now. If you're in an MLTC plan, there are certain FIs in the plan's network, and you have to use one of those. If you're in a managed care plan, same thing. The plan has a network. The same thing if you get services from HRA or your local DSS. They have contracts with a limited number of FIs, and you have to use one of those. That's how it works now. So the main differences between FIs now, the 600 FIs, are some pay more, better wages, some pay better benefits. Some provide more support. Some are sort of more mission-driven disability rights organizations that provide support to consumers and how to find and recruit and train PAs, and some don't. And their EVV, their electronic visit verification systems, are different. So now what is happening? New York is moving to a single fiscal intermediary, one, from 600 to 1. What could go wrong? So this was passed in last year's budget. The state budget said we are replacing all 600 FIs. The state did an RFP, a request for proposals, which there's a lot of criticism about, and Lou mentioned lawsuits. Lawsuits have attacked the RFP process, saying it was unfair and it was sort of rigged to select this one company, which is PPL. So the law said we're going to pick one, and it has to be one FI that has served a whole state. So there weren't any existing FIs in New York that were statewide. So they had to go out of state, and PPL is a company that has been an FI in a number of states. So all MLTC plans, managed care plans, and local Medicaid offices must sign a contract with this PPL. And they must cancel their contracts with all their existing FIs as of April 1st. So that means all the current FIs are going to lose their CDPAP business. For some of them, it means they're going to go out of business because that's the only business they had. For about 30, it's gone up from 30 to about 38 that have been selected to be facilitators, which we'll talk about later. But they're not FIs. They're a facilitator. Some are operated by the same company that also operates a traditional home care agency, Elixa. So it's like they're just two parts of the same company. So that means some of the companies won't go out of business because they still operate Elixa. So this means that there's different figures for how many people get CDPAP in New York State. I've heard 250,000, I've heard 280,000. It's a lot, however it is. All those consumers must transfer and register with this new FI, and all of their PAs, their aides, must also transfer. So it's estimated that there are about 500,000 PAs, because if you're a high-hour case, anyone with more than 40 hours a week is likely to have 2 PAs. So that's why there are so many. And of course, if you're a split shift 24-hour case, you have at least 4 PAs. So that's where we get 500,000 PAs who have to transfer and become registered with PPL. If they don't register, the state's plan is April 1st, those FIs must stop providing CDPAP, and you can only get services from PPL. So what's not changing? So the rules, the eligibility for getting CDPAP has not changed. So everything I said before about, are you allowed to hire your daughter or your parent? Or, can you have a designated representative? All that's the same. And you still have to go through NYAP, New York Independent Assessor, to be assessed as needing services. But if you already have CDPAP, you don't have to go through that assessment again. You already have CDPAP. So your hours won't change. So the authorization for the services won't change. But how you're getting the service changes, and what's the state's letters to consumers have been very confusing, because they say, the state and the FI's letter saying your authorization for CDPAP won't change. Well, if I read that, I'd think, great, I don't have to do anything. It's all good. But that's not what they meant. They meant that your approval for CDPAP isn't changing. The authorization goes to the FI, and that is ending unless you switch to PPL. So I think those letters did a disservice because they did not communicate well enough how important it is that people take these steps. Now, another thing is that some people are being told, why don't you just switch to traditional personal care? So some people are doing that. In fact, today, the state announced for the first time that about 30,000 people have changed from CDPAP to personal care. That's the first time they've issued a number. So what might change? The wages paid by PPL might be lower than what their current FI is paying. Let's see, something went wrong with my footnote here. Sorry about that. But if those wages come from the PPL website, which you see the link, and you click on the FAQ and then scroll down to personal assistant wages and benefits, and that's where these numbers come from. I've heard that some of their offer letters don't even pay these rates, but these are the rates they said they'll pay, which is minimum wage. They say they'll pay overtime, but they might not approve as much overtime as the old FI did. So that could be a problem for some people. How PAs will sign in and out of their shifts is changing because PPL uses a different electronic verification system called Time for Care, which I understand is also new in New York and hasn't really been tested. So we're nervous about changes with that being difficult. And some PAs will choose not to switch to PPL, and that could leave some consumers in the lurch. It means they have to find a new PA to fill that shift for April 1st, which is coming very soon. So these are all big problems. So now let's get into the meat and potatoes of what people have to do and what barriers they're going to face. So let's look at this status. This is literally hot off the presses. This is today's press release from the state that they say 115,000 consumers and 115,000 workers have either started or completed the registration process. Well, that's pretty vague. What does that mean? They week by week, they update these numbers, and they've never said how many have completed registration. Because a consumer's registration is not complete till at least one of their PAs is fully registered. And what we've heard are there are big delays on PPL's end in processing the PA registrations. So we think that's why they're being so cagey and not saying how many people are now payroll ready. They're really ready to hit the ground running on April 1st. If it took, this is like just 2 months to get 115,000. There's about, well, now it's about 130,000 to go. Okay, that in about 2 weeks. So that math doesn't add up in my mind, in the mind of many advocates. There is just not enough time for them to complete this. So, but I want to just say for the first time, and I want to repeat this many times, don't wait. If your clients, if you have not started this process, you must start. It is a long process. It is not just a phone call. It is a long process. It's difficult. There are lots of barriers, and the systems are not fully functioning. So you might need to be calling PPL and be on hold for 2 hours to complain and to find out why is this not moving along. So you've got to allow time for that. So I say, don't wait, start it today. All right, that's got to be the mantra for you to reach out to all of your clients, any professionals on this call, and try to help them do this. So on April 1st, workers will not get paid for work done after April 1st if the registration is not complete. There is no backup plan. The state has not set up any backup plan. The FIs are banned by law by continuing services after April 1st. Even for people who try to register and have been hit roadblocks with PPL. So, advocates are yelling and hollering about this. There needs to be a backup system, but there isn't one so far. So, okay, so let's see. Okay, sorry. All right. So what are the steps? The consumer and the PA must contact PPL or a facilitator, which I'll get to in a minute, to begin the transition. Again, don't wait. Start it now. Consumers should have received a notice from their current FI as a text from PPL. Some people are receiving texts. Their MLTC plan should have sent them a letter. Again, I feel like the state's templates for these were really misleading and didn't convey how critical this is. And they got 1 or 2 letters. A change like this, they should be getting weekly letters. There should be, a huge, huge marketing outreach campaign, and they just have not done it. The MLTC plans are supposed to be helping their consumers along, but I don't know how much they're doing. The plans are supposed to send a letter in the middle of the month. They're supposed to by then have a list from PPL as, okay, who's not registered yet? But the middle of the month, that just doesn't allow enough time for people to register. So the current FIs will not be paid for any work done after March 31st. Let's see, why is this not working? Let's see, suddenly, okay, let's see, okay. So facilitators, one way of registering is to contact one of the 37 facilitators who the state required PPL to contract with. These were all FIs before, and they're continuing in a new role after April 1st as facilitators, which is limited to customer service, helping people transition, providing EVV support. 11 of these facilitators are independent living centers that are all provide many other services to people with disabilities, and 4 of them are regional leads. But they will no longer be actual FI, so they will no longer be paid for that. or they will no longer be able to pay aides. They should help you and aides register with PPL, help upload documents. But I understand that some of them are having trouble uploading documents too, but at the very least, they can look into the system and see the status. And there's a range. I mean, I know I talked to one CD Choices in Albany, and they're doing in-person assistance in their Albany office. I've heard some ones in New York City are not doing in-person assistance. So, here's the list. I don't know why I'm having trouble. All right, here's a list of facilitators. Now, this is all at the bottom of the slide, which you can't see. You could click on it and it has all what counties each of these serves, what's their contact information, what are languages are they offering assistance in. So look for your county, call one of these. They can help both register and troubleshoot. So this is from PPL's website. All right, all right, so I just saw a comment that some facilitators are not helping people register. That I'm sure that's true. It's varied. They're supposed to help people register. I think that's what they're being paid for, transition assistance. So if one doesn't help you, call another one. So there's different ways of starting the transition. All right. By calling PPL directly, by starting it, creating an online account with PPL, and this is all the links are at the bottom of the page. That's where there's a link to create an account by email or create an account by cell phone. Or contact a facilitator, as I said, are supposed to be helping. Now, they said they'll also have a transition in person, and there's a slide here with the dates that are coming up, very limited dates for PPL to do this in person. Right, so this is from this PPL site. I don't know, the information only sessions I think are probably not really worth it, but if there are in-person registration sessions in your locality, then I would go, but there's very few. They're not all listed on this slide. So look at the link. So now one big question we get I mentioned before that 30,000 people have switched to traditional personal care. Should the consumer do that? Some FIs are pressuring consumers to do it because, as I said, they might be operated by a company that also operates a home care agency, a traditional agency, and they want to keep the business, which is understandable. But our job is to make sure, is this the right thing for the consumer? So these are some factors you must consider. Is the consumer's PA a relative who wouldn't be allowed to be the aide in traditional home care? Is the daughter the PA for her mom? Or is the father the PA for his son who has an intellectual or developmental disability? If so, that family member is not going to be allowed to be the aide in traditional home care. Now, if they want to keep them, you can't switch. All right. Another thing is the LICSA that they're telling you to join in the plan's network. Just because the FI is doesn't mean the LICSA is, and you don't want to have to change plans because that jeopardizes your authorization and plan of care for hours. All right. Number 3, if the aide becomes a certified personal care aide, they need the 2 weeks of training. Now, I've heard that some of these agencies are saying, and the aide has to pay a lot for this training. But they do have to go through training, and I'm not an expert on that, and whether there's any free training available or what, or whether they have to pay. But they're being told they have to, and it's true that to be hired by a person as a personal care aide, they must be certified, which requires that 2 weeks of training. Number 4, and this is so important, does the consumer need the aid to perform skilled tasks? Remember, I talked about this before, that the traditional aid may not perform skilled tasks, but it might be still possible to switch to personal care if the family can arrange for family or friends to do these skill tasks informally. So if it's just a matter of being able to administer medications once or twice a day, maybe the consumer lives with family who's working but can administer the meds in the morning at nighttime. But if it's round the clock, or skilled needs that are over a long period of time, then like suctioning or tube feeding, then that's not going to work. The other thing to keep in mind is that the aide will now be employee of the home care agency, and that home care agency can say, you know what, I need you to help this other consumer, this other client. I'm taking you away from the consumer you've been helping, because now the consumer is no longer in control. So that's it's a risk. It doesn't mean that will happen, but it could happen. The other thing is, even though they're similar, CDPAP and personal care are considered different services. So the MLTC plan might say, no, now you have to apply for CDPAP. Now we have to do a new authorization for a different type of service. Now I'm hoping they will just seamlessly transfer them and authorize the same hours, but there's no guarantee there. For many people that will work, and I hope the 30,000 people who transferred went through this checklist, and I hope none of them are changed where it will bite them later. But if you help people, they have to go through this checklist, and they shouldn't change otherwise. All right, so in doing this, well, what we've been hearing is that their call center, the PPL call center, promises phone lines on their website. They list a dozen phone numbers in many languages. Well, they're not really active. Our own NYLAG staff member tested the Spanish line, and no Spanish-speaking person was available. They did not answer. They transferred her to a different line for other languages, and she never got anyone to speak Spanish, and they said, call back later. That was about a week ago. Okay, so now that's just one call. I'd like to think that that's an aberration, but I've heard from many people that their language capacity is low. Don't forget, PPL for this line of business was new to New York in January. It had to staff up. So its staff are new. They're not, very experienced. They can't be. They've only been doing this work for a month or two. They're not very experienced. We've heard a lot of them are not very knowledgeable about the intricacies of this because it's complicated. So you have language problems in the call center. You have language problems on their website. Now, when I use their website, I thought, oh, there's a nice language tab on top. You could pick any language. And my colleague pointed out, no, that's thanks to your Google Chrome browser. Their own website has no language capacity. So depending on your browser, you might not see any language options on the PPL First website. I recommend using Google Chrome. I'm not paid for that. Their portal, their app that PAs and consumers use to register, I looked at it with someone. It had a language selector sort of hidden on the bottom, hard to find, but it was there. And when you clicked it for Spanish, nothing was translated into Spanish. So they have the button, but it didn't work, okay? And all the documents that have to be e-signed are only in English. So many PAs do not speak English. This is just a reality, and this is well known. All right, tech issues. There are lots of tech issues. This is, they adapted an existing website from other states to work in New York. And so everyone I've talked to has had to call PPL to talk through. I uploaded this. It's not showing up in the portal. I uploaded 6 forms. It's saying I haven't done them. I just got an email saying I better register when I've uploaded 6 forms and done everything I can. So I don't know if these are tech issues or staffing issues or both, but so you have to either call PPL or a facilitator to help. Facilitators should be able to escalate problems. They give people these very long tracking numbers and ID numbers. I've understand that the tracking number might not be necessary anymore, but this PPL ID number is very important to make a note of that, keep that handy. Now, one thing, when the consumer first registered, they're asked for their CIN number. Well, providers know what a CIN number. Many consumers don't know. Many advocates don't know. Here's the CIN number on a Medicaid card. It's the Medicaid ID number on the state ID card. So, but to add to confusion, there's also a Medicaid case number, like at least like a Medicaid notices they have a case number. That's different. This is their ID number, but that's the CIN. They will need that to register. All right. So here's another tip. The consumer, let's say the family member is the PA or the designated representative, and their mother has 99 years old with dementia, okay? They're helping mom register for herself and also themselves as this designated representative or personal assistant. They're used to always just using their email address or their cell phone number for mom, because mom doesn't have email and mom doesn't have a cell phone. So it's theirs. You can't do that. They insist that the consumer have an email address or cell number, whichever you're using, you can pick, that's different than the one that the PA is using or the designated representative is using. So you're going to have to go through this sort of sham of creating an email address for the 99-year-old person with dementia so that they have one. Now, of course, if you're doing that, you better be checking their email box because they'll get email that they might have to respond to. But this is like, if they don't do that, we've heard that there are problems later with accounts not, each person has their own, though each of these individuals will get a PPL ID number that has to have its own contact, email or cell phone number.
Valerie, we are at 12:46.
Oh dear.
We had
Okay.
hoped to leave a minute or two for questions. We do
Yeah.
have some questions queued
Okay.
up.
All right, going to speed up. All right. There's a designated representative form online you have to do. The consumer must sign a memorandum of understanding. They can, if they call a facilitator, they can do that orally. At least some of them, I guess, are not doing it. Or PPL can take it orally. Lots of problems for the PAs, as I said. I mean, these are the list of forms that they have to do. Once they upload all their work authorizations and their IDs, proof of citizenship, tax forms, once they do all this, they don't have to have a current health, well, they have to have a health assessment, but they don't have to upload it now. They just attest that they have a current one and that they know that they will have to submit it later. Eventually, they're supposed to get this job offer letter that gives them their wages, tells them they have a job. Now, I understand that some people have done all these other forms for weeks ago, and they've still not gotten a job offer letter. Then they get email saying, you haven't submitted your job offer letter, but it's PPL that has to give it to them for them to sign. So this is an example of the things that you have to look out for. All right, really quickly, I want to say, why is this happening? So CDPAP has grown. On the right, that big purple line that's going up, that's how much more money is spent on CDPAP, and personal care remains pretty level. But so okay, that's true. But why has CDPAP grown so much? We know there's a worker shortage. We know MLTC plans have told consumers, if you want coverage, do CDPAP. We don't have AIDS. All right, that's a fact. Plus, the MLTC model gives the plans a flat monthly premium. So they have an incentive to recruit more consumers who need low hours. What we've heard is that plans have deals. They have, in their contracts with the FIs, they say, you bring us 100 members who need 4 hours a day, we'll give you a better rate. Because the plan gets that single monthly premium. So they earn profits by having more members. So the state, we think, scapegoats CDPAP for the growth, but it really goes, it's really about the MLTC incentives. And this slide, if you look on the right, the big bars, look at the pink and the blue bars are low hour cases. Pink is under 20 hours a week. The blue is under about 40 hours a week. Look, that's from 2018 to 2023 in CDPAP. That's where the growth is. High hour cases haven't grown. So that helps, I think, prove my point, our point, that CDPAPs are incentivized by the MLTC model, by the plans to bring in low hour cases. Okay, so let's, all right, here's, you have REFOR, all these acronyms here, and websites. What more websites? Okay, let's do some questions.